Good afternoon, ladies and gentlemen. My name is Predrag Stojadinovic, and I'm a cardiologist and electrophysiologist at the Institute for Clinical and Experimental Medicine in Prague. And I'm going to talk about idiopathic PVCs arising from the outflow tracts with a focus on mapping and ablation. And I think that this is very important chapter in electrophysiology, physiology, especially in the era of electroporation when AFib ablation becomes more interventional procedure. So the aim of this talk is to provide some useful information mainly for the fellows, and we will discuss about anatomical considerations regarding critical sites for PVC ablation. We will see why ICE is essential not only to optimize the efficacy, but also the safety during the procedures. And we will go over some cases from real life and share some pitfalls of activation and pace mapping. And finally, we will summarize some general suggestions for PVC ablation. Outflow tract arrhythmias comprise a subgroup of ventricular tachycardias that occur in patients with structural heart disease, and approximately 2/3 of all idiopathic ventricular arrhythmias actually originate from the ventricular outflow tracts. Outflow tracts arrhythmias represents a wide spectrum of tachycardias ranging from the PVCs to sustained VTs, and they usually exhibit LBBB or RBBB morphology on ECG with an inferior axis. Most of idiopathic outflow tract arrhythmias have a focal origin. And despite the different sites, they have actually a common arrhythmogenic mechanism, which is adenosine-sensitive cAMP-mediated triggered activity. Usually those arrhythmias from outflow tracts are considered as benign condition, and the most frequent site of origin of outflow arrhythmias is right ventricular outflow tract. Remaining 25% of these arrhythmias originate from LVOT, aortic sinuses, LV summit, or aortomitral continuity. Symptoms of PVCs include palpitations or skipped beats, and patients may also experience weakness, dizziness, or even fainting, especially if PVCs comes in complex forms or as incessant arrhythmia. And this lower figure here represents the ECG tracing of the patient with the frequent PVCs with corresponding invasive arterial pressure curve. And we see that premature ventricular beats generate much smaller arterial pressure. The normal sinus beat following the PVC is potentiated and can be strong enough to cause pain or discomfort in the chest. The lack of mechanical efficiency of these PVCs may lead to concealed mechanical bradycardia, and this condition is called bradysphygmia. Some patients with frequent PVCs will develop so-called PVC-induced cardiomyopathy, which is a reversible condition if we eliminate the PVCs. In this study from the group from Michigan, PVC burden of more than 24% was independently associated with PVC-induced cardiomyopathy. Let's take a closer look what guidelines say about catheter ablation of idiopathic outflow tract arrhythmias. We see that only in a case of PVCs originating from the RVOT, catheter ablation is recommended in preference to beta blocker of propofenone. And for all other sites or arrhythmias, for all other sites and also for the complex forms of arrhythmias, catheter ablation is or can be useful. If antiarrhythmic therapy is ineffective, not tolerated, or not a patient's preference. But in the real life, we know that the patient's preference is extremely influenced by the fact how we explain the patient's the importance of catheter ablation. Outflow tract is a complex and it's an anatomically very condensed region with overlapping critical sites in close proximity. And this is my first anatomical consideration, and that is the RVOT is more anterior and it's more to the left of LVOT. RVOT has two parts. As we know, it's the septal part and a posterior part that can be divided into the anteroseptal part, midseptal part, and posteroseptal part. And here you can see that anteroseptal part is in the close proximity to the left anterior descendant artery, and posteroseptal part is in the close proximity to the RCC. LVOT is the actually elliptical opening of the LV that is composed by the aortic root, which is more rightward and anterior, and the mitral valve, which is more posterior and leftward. Between these two valves, we can find a fibrotic curtain that is called aortomitral continuity. And the aortic root is the central part actually of the heart that consists of three cusps. It's a right coronary cusp that is more anterior and rightward to the RVOT, LCC that is more on the left, and it's in the close proximity to the anterior part of the mitral annulus, and NCC that is more posterior, and it's the most inferior cusp of the aortic valve. Just below the commissure of the RCC and the NCC is the fibrotic septum with penetrating bundle of His. So if we are ablating some, for example, atrial tachycardias from the NCC, we need to be aware of damaging the His bundle. So before every procedure, actually, we must analyze surface ECG in order to predict the site of origin of the ventricular arrhythmias. And in the past, several ECG algorithms have been proposed for localization of the site of origin of the PVCs. I must say that clinical utility of these algorithms may be reduced by especially by its complexity. As you can see on this slide, it's very hard to memorize all these points, and also accuracy of these algorithms may be limited by different parameters such as lead position, the chest deformities, or just by rotation of the heart. And another problem is with another reason for the low accuracy of these algorithms may be the phenomenon of preferential conduction, because in some patients with the PVCs coming from the aortic sinus, we can have a preferential conduction of these PVCs and exit to the RVOT. The success of catheter ablation for the PVCs is also dependent on the presence of the PVCs during the ablation. If we don't have spontaneous PVCs during the procedure in the EP lab, we can try some maneuvers, and indeed hand grip or isoproterenal administration may be helpful. You may also try a burst stimulation, either atrial or ventricular. And for the sake of curiosity, I'm going to show you the video from our EP lab. This is actually a patient with the frequent PVCs, but in real life, but no PVCs in the EP lab. And this can be really frustrating. And in this patient, we asked this patient to take a deep breath to make a Valsalva, and all of a sudden there was a PVC bigeminy, as you can see. Now patient is breathing normally, and PVCs are gone, actually. And then we tried once more. We asked him to do a Valsalva maneuver, as you can see here right now. And again, there are PVCs. So I'm not telling you that this is working in all patients, but at least you can try to just to catch at least one PVC to have a morphology in the EP lab. RVOT arrhythmias exhibit LBBB-like morphology with late transition, but that is also later during the sinus rhythm, and especially without broad initial R wave in right precordial leads. Inferior axis is typical for all outflow tract arrhythmias. We actually distinguish two, as it was said, two parts of the RVOT, which is a septal part and the free wall part. The main difference between them is that, in contrast to the septal side, free wall sides have a later transition, as you can see here, and also has a wider QRS with notching, and also less positive QRS complexes in inferior leads. Septal RVOT can be divided into the anteroseptal part, midseptal part, and posteroseptal part. And the main difference between the septal part of the septal sides of the RVOT is in lead 1. If we have a patient with anteroseptal RVOT PVCs, the morphology of the QRS in lead 1 will be more negative. The reason is obvious, because anteroseptal part is more leftward than posteroseptal, where the QRS will be more positive. And if the midseptal part usually has this polyphasic or multiphasic QRS complex with dominant negative deflection. So the second anatomical consideration I would like to emphasize here is that myocardium extends above the pulmonary valve, and it's usually our origin of idiopathic arrhythmias. These myocardial extensions can be visualized on the eyes, as you can appreciate here, and sometimes it can be very challenging for ablation of these sites can be very challenging. In some cases, ablation catheter has to be introduced deeply in the pulmonary artery, usually with the help of the long steerable sheet, and then this catheter has to be flexed and pulled back to get in a good contact with these myocardial extensions. So if we have a patient with PVCs coming from the RVOT, we usually start the procedure by creating a basic anatomical shell of the right ventricle. We tag his bundle, tricuspid annulus, and also pulmonary annulus. And then, if there are spontaneous PVCs, we are doing activation remap. And during the procedure, we need to analyze the bipolar signals, but also unipolar signals. We are interested in their, especially in their prematurity. And once we have the earliest focus that is bracketed, we perform ablation. We are using, in all cases, irrigation tip catheter and 25 up to 30 watts. During the ablation, we observe the response to radio frequency, especially time to suppression of the PVCs, but also time to recurrence. If there are no PVCs, we can use pace mapping. It can be helpful, but there are some severe limitations that we will see in the next slides. So here I would like to emphasize the limitations of the activation mapping. We know that location accuracy of the 3D mapping systems is decreased during the PVCs, and this is due to the abnormal electrical and mechanical contraction of the of the ventricles. So here we see the catheter position during the PVC and during the sinus rhythm. We are not moving the catheter. This is just a movement and dislodgement caused by this abnormal contraction. So before RF ablation, we need to realize that the earliest point and the best points for the successful ablation may be out of this red color of the activation map. The main reason why pace mapping is less accurate is the very low spatial resolution of the pace mapping. In other words, this means that the similar pace QRS morphology can be observed in almost 2 square centimeters in the RVOT. And Cartopasso, we can also use Cartopasso. Cartopasso is a mapping module that allows automatic comparison of the QRS complex morphology during the PVC and during the stimulation. And here I want to show you the case of the PVC originating from the commissure between the RCC and LCC, where we perform this pace mapping, and you can appreciate the perfect pace map morphology here with very long pace to QRS interval. However, the global correlation on the Cartopasso was only 85%, and this is due to very flat QRS complexes in lead 1 and lead V6, where a minimal change can significantly decrease the correlation percentage. And this is a terrible case, actually, of PVC ablation from the USA. This was a 36 years old lady with idiopathic PVCs from the right outflow tract arrhythmias, and the PVC was successfully eliminated in the RV horn, which is the place where RV wraps around the septum, the actual septum. And after this ablation, after elimination of the PVCs, patient developed chest pain with corresponding ST elevation on the 12 lead ECG. So they performed this coronary angiogram that confirmed the obliteration of the LAD in the middle part. This is a 36 years old lady with idiopathic PVCs, and so they had to perform the PCI, and they implanted the stent. Hopefully, this lady had a normalized ejection fraction after this, and in our experience, 40 watts for 60 seconds in one place in RVOT is too much, and this is an energy setting they used in this during this procedure. So so it is much wiser in a case of fatal ablation. It is much wider to map adjacent structures before increasing the power, and this case is a good example of that. Here we have the patient with frequent PVCs with RVOT morphology, where we started mapping, and in the posteroceptal region of the RVOT, just below the annulus, we found this very nice signal with very nice prematurity, actually there was a very good acute effect here with suppression of the PVCs, and we decided to put some more ablation, like safety ablation, in close proximity to the first application. And during this ablation, we saw this ectopic rhythm that was very just transient, but had identical morphology as clinical PVCs. And after 50 minutes of waiting, we had our clinical PVCs were coming back. So we decided to map the right coronary cusp, and we mapped actually aorta, and in the right coronary cusp, we had this signal, which is very nice. Here we did ablation, and during the first application, the PVCs were gone. So now we can debate if this ablation in the RCC would be enough in this patient, but in our experience, you may start mapping and the ablation in the aortic root, but sometimes you still have to go to the opposite side, to the RVOT, and to ablate from the other side. And this is so-called sandwich ablation, which is very effective, especially if the focus is located deep in the tissue. Okay, so LVOT is the origin of 25% of all idiopathic ventricular arrhythmias, and it is divided into 3 regions, which is supravalvular, that is represented by Valsalva sinuses, where we can find myocardial extensions, especially in the RCC. NCC is the site of some atrial tachycardia, because usually in the NCC we can find the atrial connections. Endocardial LVOT arrhythmias originate from the area below the aortic valve, or from close proximity to the aortomitral continuity. And finally, epicardial origin, which is the most challenging, is represented by LV summit and the area of great cardiac vein. The main differences between RCC and LCC morphology of the PVCs is in lead 1. Since RCC is rightward to RVOT, it produces more positive QRS in lead 1. In contrary, QRS in the PVCs coming from the LCC has more biphasic QRS complex with dominant negative deflection. This is a case of patient with PVC originating in the LCC, and on this case, I would like to emphasize the role of intracardiac echocardiography during mapping and ablation of the PVCs arising from this outflow tract area. First, when we deal with arrhythmias coming from the aortic cusps, we want to avoid damage of coronary arteries. And with eyes, we can easily visualize ostium of the right and left coronary artery without performing the coronary angiogram. And the ICE is also very useful for monitoring the catheter position and stability. And on this modified home view, you see the sliding of the catheter that may prevent the good lesion formation. So instead of increasing watts, we should first optimize the catheter stability. At this region, we usually we use in all cases irrigated tip catheter, and 25 up to 30 watts and duration of 30 to 60 seconds for each application. Aortomitral continuity is, as it was stated, fibrotic curtain which extends between the anterior leaflet of mitral valve and the LCC and RCC of the aortic valve. And arrhythmias arising from this region have usually RBBB morphology with biphasic QRS in lead 1, which has a dominant negative deflection. And usually in PVCs coming from this area, we can find a small, tiny Q wave in lead V1. For successful ablation in this region, we need to introduce ablation catheter deeply in the ventricle, and then to flex and pull back in this, as we call it, backhand fashion. This will optimize the contact with the tissue, and but if this is not helpful, we are using this forehand maneuver where we introduce the catheter and flex it just below the cusp. And sometimes we even have to go above to the aortic valve, to the aortic cusp, and to make a previously mentioned sandwich ablation in order to increase the efficacy of this catheter ablation. LV summit is the region on the epicardial surface of the LV that is bounded by LAD and circumflex artery. And because of that, ablation of the PVCs in this region can be very challenging. This region is actually divided by the great cardiac vein into the proximal side that is accessible for ablation and distal part that is not or inaccessible for ablation. And these two parts have unique ECG characteristics as well. Distal part has more LBBB morphology with late transition, and it has a more negative deflection in lead 1, and also AVL or QRS in the AVL is less positive than QRS in lead AVR, which is in contrary with proximal of or accessible site of the LV summit, which has a RBBB morphology with obviously early transition, and also QRS is biphasic with initial R wave and dominant this S wave in lead 1, and also QRS in lead AVL is more negative than QRS in lead AVR. And here I wanted to show you one case from our workshop from the last year. We had a patient with one previous failed ablation, and he had this proximal or accessible site morphology with biphasic QRS and RBBB morphology. And actually in this patient, we since unipolar ablation failed, we used bipolar ablation between passive catheter that was introduced into the great cardiac vein and active catheter that was introduced retrogradely into the LV in this backhand fashion. And indeed, ablation between these two electrodes was successful in eliminating the PVCs from this region. Okay, so in conclusion, ladies and gentlemen, I would like to summarize some general suggestions regarding mapping and ablation of ventricular arrhythmias arising from the outflow tracts. First of all, presence of the ventricular arrhythmias at the time of the procedure is needed, so we need to avoid drugs. If spontaneous ventricular arrhythmias are absent, hand grip, burst stimulation or isoproterenal administration may be helpful. Before the procedure, we need to analyze surface ECG, but we need to realize its limitations, especially if we are using some ECG algorithms for predicting the site of the origin of ventricular arrhythmias. During the procedure, we need to analyze intracardiac electrograms. This is an EP procedure. This is not interventional procedure. We are interested in timing prematurity of the signals, but also we need to realize morphology in bipolar and unipolar setting. If we have a patient with LBBB-like morphology of the PVCs, we should start in the RVOT, and when mapping indicates the focus outside of the RVOT, we can map the great cardiac vein actually prior to the left side catheterization. And ablation of the PVCs coming from the outflow tract is based on activation mapping, so we should not rely on pace mapping, or at least we should know the limitation of the pace mapping. During the ablation, we need to observe the response to the RF energy application. Especially, we wanted to know what's the time to suppression, what's the time to recurrence of the PVCs. And most of all, I would like here to emphasize the role of intracardiac echocardiography that is essential for ablation, not only for the outflow tract ventricular arrhythmias. Thank you for your attention.
Good afternoon, ladies and gentlemen. My role is today to talk about PVCs or VTs from non-outflow tract regions. That's a little bit different category. And these are my disclosures. And you already heard that idiopathic VTs or PVCs are arrhythmias in the absence of organic heart disease, and we can classify them according to the origin, arrhythmogenic mechanism, or reaction to drugs. And there are many places or many sites of origin. You already heard talk about origin in outflow tract, whether it's right or left. And we will talk now about the VTs arising from other LV sites or from other RV sites. And we will not talk about fascicular arrhythmias because that's another lecture. Papillary muscles are a very specific area where these arrhythmias can come from. And this distinct clinical syndrome was described quite late in 2008. And that was mainly because the advent of intracardiac echocardiography. And in the first paper, they already suggested that maybe the origin is mainly in the base or middle portion of papillary muscle. But in reality, we believe that it's the apex, and I will explain later. And this is a characteristic pattern of this arrhythmia from posteromedial papillary muscle, which is more frequent. You see superior axis and right bundle branch block with a transition zone somewhere between V3, V4 in the middle of ventricle. In the second paper from the same group, they found that excellent pace map was really changing, and probably the source is higher or deeper in the papillary muscle, and the ablation was quite successful. And then eyes allow to see really the whole anatomy of the papillary muscle, and already first papers using eyes describe that apex or tip of the papillary muscle is probably a source of origin. So my advice number one is that ablation on papillary muscles requires optimally online imaging, like intracardiac echocardiography. When you use intracardiac echo, you see that the anatomy of papillary muscles is very variable. This is a large anterolateral papillary muscle on left side. You see two heads. You see here the right on the right panel. You see quite let's say large area of attachment of small anterolateral papillary muscle here, and here is a posteromedial papillary muscle coming a little bit into this picture. Here we see that you can really, using eyes, you can go in between two heads and you can see activation in this area. You can go to the tip of one of these heads and you can see that activation could be better or worse, and you can really ablate under visual control. You can also reconstruct individual map in 3D with electroanatomical mapping system, or you can use cartosound to have such pictures like on this in this paper. And this paper showed nicely that intracardiac echo significantly improved the results of ablation because you know what you are doing. We learned also that pace mapping is not good because of catheter instability, so activation mapping is preferable for ablation of these structures. And we also learned that if you do ablation, usually there is a ectopy, and ectopy creates a lot of movement and instability of the catheter, as you can see here on left panel. But if you pace the right ventricle faster, then you can stabilize the catheter. Here we see the pacing from right ventricle, and you see that the catheter is not moving as it was in the previous case. We also published data from multi-center observational study, 34 patients in 4 centers, posteromedial papillary muscle is predominant, 56 cases, 56% of cases. Anterolateral is less frequent, and you can have also from both sides. All procedures were guided by eyes, and suppression of ectopy was achieved in 86% of cases, a significant decrease of burden. And we also looked at the anatomy of papillary muscles, and you see that posteromedial is usually longer, and also anterolateral is, on the other hand, wider, usually with a clear, distinct two heads. And we found that tip of the papillary muscle is a predominant site of origin of these arrhythmias, and not the base, as suggested earlier in these early studies. What to do if you cannot ablate because of instability? You can switch to cryo. And this was a case report showing, this is already a case series, showing that if you use cryo catheter, you can attach the catheter to the muscle during freezing, and you can be more successful than with a radio frequency current. And this is another study from another group showing that really cryo is preferable since it provides better stability and better results in long term, as you can see from this graph on the right side from Kaplan-Meier curve. Right papillary muscles are even more complex than on left side. You see that the right ventricular area is really very complicated, and you see that there is a moderator band and there is attachment of septal and anterior papillary muscle. And this is a typical case. You see ECG with, again, superior axis positive in lead 1 and left bundle branch block with a relatively late transition. So this ectopic cannot come from RVOT, cannot come from posteroseptal recesses, cannot come from posteromedial papillary muscle, because that would be a right bundle branch block. So it's a moderator band ectopy typically. And here you see on eyes, again from right atrium, you see that you are here, this is a moderator band. And you see here that there is a conduction system coming to this area, and you can ablate successfully under visual control. Another anatomical picture, and this is from UPenn group, again showing that with the eyes you can really go around this structure moderator band, and you can ablate successfully. What is interesting that in this group they found that a lot of these arrhythmias, a lot of these ectopic beats really creates not only monomorphic VT, but also a ventricular fibrillation, focally triggered ventricular fibrillation, and you can ablate this source of origin of this ventricular fibrillation. What about other locations in RV? This is an illustrative case of a female with palpitations with frequent VPBs on Holter. She was intolerant to medication, and you see 12-lead ECG, and you see very positive in lead 1, 2, and less positive in lead 3, left bundle branch block. And so this cannot come from RV apex, cannot come from anterior RVOT or posterolateral tricuspid, because the axis would be different. So it's a parietal band. And this is a structure of muscle which is close to tricuspid valve, and I will show you immediately. And this was a site of ablation. You see 14 milliseconds. And you see here is aorta, and here you see right ventricular outflow tract, and this is tricuspid annulus, and here a little bit lateral from the tricuspid annulus is this structure, which could be seen in next slide. You see here, we used Adjourn to bend the catheter, hook it underneath the leaflet of tricuspid valve, and to ablate in this area. And you see here, this is the structure, this muscle band, which is called parietal band. And this is typically close to the lower part of the outflow tract, very close to tricuspid valve, sometimes very close to the valve, sometimes you have to ablate a little bit higher or more lateral. Another area is peritricuspid area or tricuspid annulus. And you see here on this in this paper, they found a lot of these foci in the septum or around the tricuspid annulus on free wall. And septal location was more frequent, but these arrhythmias are broader with QRS, and they have notches on free wall because it takes some time to go from this side and this side. And transition is usually beyond the V4. Here you see typical pattern again, positive in lead 1, depending if it's anterior or posterior or superior or inferior, whatever is the terminology. And then left bundle branch block with late transition. In this area, the steerable sheath is often useful as it is in right-sided accessory pathways. And this is an interesting case. You see, again, typical morphology suggesting that it's somewhere in a lateral area, rather inferiorly. And here we have a signal at the earliest site. So you see unipolar signal, also bipolar signal quite early. And here we see the map. His bundle area here is a lateral area where the arrhythmia comes from. You see here on ice that the catheter is embedded underneath the leaflet of the valve. And you see here steerable sheath enables you to do this mapping very nicely, and there is the effect of ablation. Another area, septal area, where you have to use a sheath, and you can go beyond the septal leaflet of the tricuspid valve. Again, here you see typical morphology. It's a perihesian or in vicinity of his bundle. Positive here, and this one is usually negative in lead 3 or AVF or bipolar or biphasic, let's say. And when you do this bend and you see that tip of the catheter is almost kissing the shaft, it's very close to his bundle area, as you can see here. But because you are below the leaflet, you are separated from his, and you are separated from AV node by the fibroskeleton. You can do ablation successfully, and this was described also in literature as a case reports, but we described also this entity with my colleagues in Europe's journal. Crux of the heart is something which is a very strange area, and it's opposite to the summit. And depending again, if you are more basal or more apical around the crux, you can have typical morphology. The more basal you are, the more positive they are in V leads. And this is not so important, but the important thing is that you have to map all different structures around, similar to summit, because otherwise you may miss the best opportunity to ablate. This is an illustrative case, a patient with a moderate dysfunction, a lot of PVCs, 2 previous unsuccessful PVC ablations. You see here superior axis, quite early transition, so suggesting it's more from basal part. And this is a right ventricular mapping in that area, so it's -15. If you go then to coronary sinus and tributaries, you have better prematurity here. You see injection of coronary sinus. Then you can go epicardial, what we did, and there is a far field signal. So it was not really epicardial. And if you go to the left posteroseptal space, there is some fragmentation at the beginning. So this was quite early, and the ablation was successful in this area because there was also a reasonable pace map. And you see that immediately when we started ablation, the ectopy disappeared. So you have to map all around. Other locations in the left ventricle, VTs from mitral annulus. Again, a very specific entity. And you have, because it's from mitral annulus, it must be positive from V1 to V6. And again, depending on location, whether it's superiorly or inferiorly will be the axis. And you see that predominantly it's from anterolateral area. And there is a typical case again, a lot of ectopy, complaining of low tolerance of exercise. You see that this is, again, superior axis. So it must be from posteroseptal space from the recesses of the left ventricle. You see positive from V1 to V6. And here we have only a limited map of posteroseptal left ventricle. And this is annulus, these are blue points, and this is an area of the recesses. And the ablation was successful on that spot. And this is another advice that you don't need to complete the whole map of the structure if you really know where you are, and you just need a regional map for annotation of your site of interest. We can also find some foci epicardially. So if you cannot find endocardial site of interest, you have to go epicardial, which is already higher level for most of the operators. This was a young man with palpitations and syncope. He had documented frequent VPBs, normal echocardiogram, normal MRI. And he had already ablation of avian artery and atrial flutter. He presented with this VT, which is clearly from the outflow or from the summit area, let's say. But you see there is some slurring of the initial part. And we did mapping of right ventricular outflow tract, left ventricular outflow tract, aortomitral continuity. And then finally, we went epicardial. You see the focus is here, but the problem is that it was just next to coronary artery. It doesn't move here, but anyway, we decided to go for mini thoracotomy and do some limited mapping in a surgical theater, and then cryo of this area, and patient is driving a truck again because we get rid of this arrhythmia. Today, we would do it with a surgeon in the EP lab. We started this program 2 years ago, and we can do mini thoracotomy in our EP lab, and we can use electroanatomical mapping system or all our technology to get rid of these arrhythmias. So whenever you cannot get reasonable endocardial activation, go epicardial or send patient to some center where they can do it. Ectopy from left Purkinje system. This was our case we described back in '99. It was a patient with a history of cardiac arrest, positive family history. His heart was normal, but he suffered from repetitive bursts of polymorphic ventricular activity and ventricular fibrillation. He received ICD, and when he had the exchange of the box, he developed storm. And you see this was endocardial mapping. You see Purkinje potential here, and during ectopy, this is of this ectopy, and this was before the advent of electroanatomical mapping system. Here you see ablation catheter on the septum, and later we did collaborative study with Michel Hassager, and this was the first publication in 2002 in Circulation. So in these cases, 12-lead ECG is very important because then you know where to go and ablate in Purkinje system. My other advice is that you can use electroanatomical mapping system in the right ventricle if you want to exclude ARVC. This was a young lady, and she had a history of panic attacks. She had palpitations and a normal physical exam. All examinations of her heart were normal. She had rounds of non-sustained VT with spontaneous termination. It was also during ergometry. And because her aunt had cardiac arrest, but she was old and she had diabetes, and in other center they said that it might be ARVC. The patient was advised to get ICD without any other documentation of ARVC. She came for second opinion, and this is her ECG. You see no signs of ARVC. This is arrhythmia, which was recorded on a Holter ECG. Here we see again the same arrhythmia from outflow tract of the right ventricle, as you can see from ECG pattern during ergometry. And our second opinion was that this patient had idiopathic ventricular tachycardia, and we recommended her to undergo ablation, but also during ablation, we will do electroanatomical mapping to confirm the diagnosis and exclude ARVC. We did mapping, and there was normal voltage, and the patient had focal activation in the posterior part of the right ventricular outflow tract, and ablation was successful. The patient is now more than 2 years without any arrhythmia. She became pregnant right now. And you see the voltage map is pretty normal. There is even in unipolar map, there is no low voltage area. This is the area view. And you see here the focus was in posterior part of the right outflow tract. So this was my last case and last advice. And I would like to conclude, ladies and gentlemen, that VPBs or VTs can originate from other locations in the right or left ventricle outside of outflow tracts. ECG is, again, very important tool to regionalize the site of origin and then do careful mapping of activation sequence, sometimes complemented with space mapping. And we need sometimes electroanatomical mapping system, but we don't need to really do the whole map, but just a regional map to be successful. And we need often intracardiac echo to see the structures where we are ablating. And some locations are quite difficult and require a high level of expertise. So whenever you cannot ablate, you should send patient to the expert center, because the worst thing is that you cannot do something, but you keep patient on drugs and do not send him or refer him to a center with more experience. So thank you very much for your attention.
Ladies and gentlemen, my name is Štiavnicky and I am in a starting line in the EP world. From my first procedure, catheter introduction, and performing my first simple ablation, I'm continuously learning of making it more effective and in safe way. In this presentation, I'm going to briefly talk about possible complications and a way how to avoid them. Catheter ablation has established itself as a first-line therapy in the majority of supraventricular and ventricular tachyarrhythmias. Long-term success of catheter ablations of different types of arrhythmias is impressively high and often exceeds 95%. On the other hand, catheter ablations may be associated with complications. Firstly, given by the invasive nature of catheterization procedure in general, for example, obtaining multiple vascular access, intravascular catheter insertion, and performing transeptal puncture. And secondly, related to the type of performed procedure, intravascular and intracardiac catheter manipulation and application of radiofrequency energy. I'm going to divide this presentation into three parts: red flags and knowing your enemy, describing possible complications, their rates, and experiences across task forces, guidelines, and registers. Second part, safety approach, will be interactively focused on standardized approach. And third part, be prepared and analyze, will describe the way how to continuously improve safety approach by the system of standardization and analysis of complications. Characters of complications and their rates differ across different types of procedures. That's why first we are going to talk about conventional ablations and then complex ablations, in which incidence of complications depends on more factors and patients' comorbidities. This table describes basic potential complications in individual supraventricular arrhythmias and their incidence rates according to European Society guidelines. Risk of complications of supraventricular ablations is within the range of 0.3 to 1.5% according to the type of arrhythmia and site of ablation. Mainly include vascular complications, pericardial effusion, and specific complications such as AV block. AV block can be present in ablation near AV node, especially during AV and RT ablations, or during AV-RT ablations, complete AV block occurs during ablation of the septal and posterior septal accessory pathways. Its incidence is reported to be around 0.5%, but in the workplace with extensive experience, the actual incidence is much more lower. Complex ablations. Catheter ablation of atrial fibrillations and ventricular tachycardia is a complex procedure that has a number of steps and requires intranseptal puncture, or especially in VT ablations, retrograde access using femoral artery and multiple manipulation of catheters. Therefore, it is not surprising that the incidence of complications of atrial fibrillation and ventricular tachycardia catheter ablations exceeds the number of complications of conventional ablations. Risk of complications during atrial fibrillation ablations depends on many variables. It's a complex procedure with a multiple venous access and high-level anticoagulations. There is also need of transeptal puncture and complex left atrial manipulations of catheters. During ablation, there are a large amount of ablations lesions in the thin atrial wall. Specific complications depends also on surrounding structures, such as esophagus. The most common complications of ablation for atrial fibrillations are vascular complications such as pseudoaneurysm, arteriovenous fistula or hematoma, cardioembolic events, stroke and transient ischemic attack, and perforation of the heart wall, effusions or tamponade. Rarely, a fistula may form between the left atrium and esophagus. These complications, together with cardiac tamponade, poses the greatest risk of the possible performance-related death. Deaths are reported in a worldwide atrial fibrillation ablation survey at 0.15%. Lower rates complications include pulmonary vein stenosis or diaphragmatic nerve damage, atrioventricular block, mitral valve damage, pericarditis, or vagal nerve damage. Selected prevention techniques consist mainly on controlled power force or posterior wall, catheter manipulations, monitoring of diaphragm during phrenic pacing, and ultrasound-guided venipuncture. The incidence of complications after ablations for AFib is reported in various registers in a range of 3.9 to 6%. Data from large centers with a large number of procedures indicate the occurrence of complications in the range of 3.3 to 5%. These two tables shows worldwide survey on methods, efficacy, and safety of catheter ablation for AFib and its update. Major complications occurred in 6% of patients. A rate of tamponade of 1.2% is somewhat higher than commonly observed and is likely to be related to the combined influence of catheter manipulations in the left atrium and the need of continuous intravenous anticoagulations during the procedures. Finally, the overall incidence of major complication in present survey appears higher than that reported in a single center reports, finding that, again, may reflect the learning curve involved with the specific ablations procedures. What is important to know is the prevalence and causes of fatal outcome. This table shows causes and proportions of death in more than 3,000 patients. The higher rate of early death within 30 days after procedure was mainly in connection with tamponade atrial esophageal fistula or peripheral embolism and stroke. The highest rate of late death after 30 days after procedures was mainly in connection with stroke. Let's compare it to our high volume experience of total more of 1,000 consecutive AF ablation procedures in 959 patients. We observed overall major complications over about 3.36%, in which tamponade and stroke were observed in 0.25 and 0.17% cases respectively. Risk of complications during ventricular arrhythmia ablations depends on many factors. Mainly, it's a complex procedure with a multiple venous access and also anticoagulation. There is need of transeptal puncture manipulation in aortic root or crossing the aortic valve in retrograde access using femoral artery. The nature of ventricular arrhythmia is also different. In vast majority of cases, they are re-entry arrhythmias that originate from scar tissue and require much more substrate modification, and thus much more complex ablation with many energy applications. This table demonstrates possible complications, their incidence and mechanisms. Because of mentioned factors, VT ablations are connected with higher risk of mortality, mainly because of VT recurrence and heart failure. Similar numbers have neurological and pericardial complications up to 2.7% related to emboli, catheter manipulation, and heart perforation. Other complications can be coronary artery damage and valvular injury up to 1 to 2% and related to ablations and catheter manipulations. Large group are vascular complications which are related to multiple vascular access and often retrograde approach using the femoral artery up to 6.9%. Overall major complications with structural heart disease in ventricular tachycardia ablations is in a range of 3.8 to 11%, and overall all complications between 7 and 13%. What is important to say is that in ventricular arrhythmias with structural heart disease, a higher incidence of complications can be due to the severity of patients' clinical conditions, advanced heart failure, and also other associated diseases. Let's have a look at our high volume experience. The incidence of complication in idiopathic ventricular arrhythmia ablation is not fundamentally different from the complications in conventional ablations, shown in the left column. Right column shows ventricular tachycardia ablation in structural heart disease, in which overall incidence of complications was 8%. From which the most vascular complications 4.7%. Other perforation and thromboembolic events below 1%. Next table compares summary of single center experience VT ablation in structural heart disease, tamponade in a range of 0.4 to 2%, cerebrovascular accident below 1%, and vascular complication in range of 2 to 4.7%. US inpatient care database collects more than 80,000 patients in which with post-infarct VT, from which 5.7% had catheter ablations, and they demonstrated any hospital complications of 11.2%, and the most of them vascular complications 6.9%. To sum up, predictors of complications rises from conventional ablations to ventricular ablations in structural heart disease and arrhythmic storm ablation. And main predictors of complications are reduced ejection fraction, higher creatinine, increased age, and operator experience. In the next part, I show you interactively how to perform basic maneuvers of catheterization procedure in EP lab. Let's start with ultrasound-guided cannulation. Vascular complications are the most common complications, and the main factors that contribute to a higher incidence include multiple vascular access and high doses of anticoagulation during procedures. Recently published data by Dr. Plašek investigated gender differences in major vascular complication in patients undergoing ablations for AFib in high volume center. This study demonstrated 4% of major complications and proved that females have a higher risk of multiple vascular complications following ablations compared to males. And this difference was driven by lower body size in females. Important for us is that ultrasound-guided venipuncture lowered major vascular complications rate. The next table, timeline of major vascular complications, shows development of complications based on more standardization, uninterrupted anticoagulation, and ultrasound-guided venipuncture, and shows a trend towards the decrease over the time. Ultrasound-guided venipuncture is easy and fast. You need a sterile gel and a vascular probe cover. Then you put it together on a vascular probe, and finally you perform vascular access. The image you see on the monitor shows you tenting of a needle on the upper wall of femoral vein, and the key concept using ultrasound-guided venipuncture is to visualize the tip of the needle and it's entering to the basal lumen. Recently presented data by Dr. Hašková at the European Heart Rhythm Congress demonstrated vascular complications rate of ultrasound-guided venipuncture that were analyzed and compared to historical controls with an anatomical landmark-guided approach. The study cohort consists of more than 4,000 patients and proved that ultrasound-guided venipuncture was associated with a statistically significant reduction of major vascular complication. This strategy also decreased the need for surgical correction of vascular complications. And for what is interesting is that multivariate analysis revealed that ultrasound-guided strategy, male gender, and less advanced age were significantly associated with lower complications rate. The other study, UltraFast trial, compared 5 centers, 320 patients, randomized 1-to-1, and proved that the benefit of ultrasound-guided venipuncture is also for beginners and experienced operators. Catheter, the next step after ultrasound-guided venipuncture is a wire, sheath, and a catheter introduction. Here I have some tips and tricks on how to perform it safely. Check wire position under X-ray. Alternatively, you can do it fluoroless using electroanatomical mapping system, hydrophilic wire in case of conventional wire does not proceed, and also use of low threshold for angiography in case of problems. Other tip is to introduce the catheter with the anterior bend to minimize probability of hooking tip into the branches of vena cava inferior. Sometimes there is no way to get there from below, and these two cases shows the use of visualization using X-ray and contrast injection in case it doesn't go smoothly. Do not rotate the bind with the catheter during introduction. This case report demonstrated manipulation and rotation with the catheter can lead to a complication. Introducing was performed without fluoroscopic guidance. When fluoroscopy was used, it revealed knotted catheter. Gentle traction and rotation did not allow catheter withdrawal. And finally, eye-tying knotted diagnostic catheter in the pelvic veins was performed with a steerable sheath and ablation catheter introducing from internal jugular vein. The key to a successful catheterization of the left heart chambers is the safe transeptal puncture. Intracardiac echo is an attractive tool used in a cardiac catheterization and EP labs to provide detailed images that can facilitate transeptal puncture. Not using imaging modalities to ensure needle position may result in accidental puncture of aortic artery or the atrium wall, sending the patient in a cardiac tamponade. After access groins and sheath insertion, you insert needle and a pullback of holder system. Hold the sheath together with the needle at the 5 o'clock and using eyes visualization, pull the needle and the sheath until they fall in the fossa. And then you see these three leftward movements. The first into right atrium, second around aortic mouth, and the third directly into fossa ovalis. And this step can also be in this video. Puncture and advancing the needle into the left atrium is the last step of successful transeptal puncture. Using gentle forward movements with a gentle pressure, advance the needle while keeping this transeptal sheath in a place. And as gentle forward pressure is applied to the needle, septal tenting is observed on the eyes, and then you can see the direct position of the needle in the septum. Challenging anatomies for transeptal puncture may include abnormal anatomy like dilating ascending aorta, rotation of the heart, kyphoscoliosis or mitral stenosis, and on the other hand, difficulty to cross the septum. For example, in the case of aneurysmatic fossa ovalis, lipomatous hypertrophy, crossing the interatrial buffer, or atrial septal closure device. The possible troubleshooting techniques can be eyes navigations, confirming the position with fluoro, contrast injection, increase the curve of the needle, applying radio frequency energy, and consider the J-shaped wire. How to cross the difficult septum? In this case, I will show you some possibilities and tips and tricks on how to cross this difficult septum. Safe set is the transeptal guide wire. The very sharp tip of the safe set requires less force than a conventional transeptal needle to cross the intraatrial septum, making it easier and especially in a difficulty or previously failed cases. The other possibility is the use of radio frequency delivery. You see in the left picture the connection of catheter and a needle, and in the right side, the whitening of tissue of intraatrial septum during radio frequency energy delivery. Intracardiac echo guided transeptal puncture enables visualization of individual anatomy, identification of fossa ovalis, and the possibility of transeptal puncture at selected site of the septum. What is very important during the procedure, as you see on the eyes videos, is online imaging. In these eyes pictures or videos, you see the benefits. The first is online assessment of anatomy. Eyes can be used for online imaging of pulmonary vein, ostia, esophagus, and assisting accurate placement of both manipulating and also ablation catheter. Then prevention thromboembolism. Eyes may help to identify thrombus whenever it develops during a procedure. Then monitoring of radio frequency current delivery. Radio frequency energy application may cause perforation of the heart due to tissue superheating that follows steam pop you see in a video on a screen. The prevention is based on flow for irrigation of the ablation catheter and monitoring of the tip temperature. Any rise of temperature above 40-42 degrees Celsius means high level of tissue heating and prompts down the regulation of power. Similarly, we check tissue characteristics during radio frequency application. Any sudden whitening of the tissue is a reflection of high temperature. Early detection of complications. One of the most important roles of intraprocedural online imaging in EP lab, for example, in the case of cardiac tamponade. Cardiac tamponade is the most worrisome complications. In such cases, intracardiac echo can provide early diagnosis and thus prevent tamponade due to early reversal of anticoagulation. And in case of tamponade, ICE allows online monitoring of the patient's status. Other part is a prevention of thromboembolism. Thromboembolic events are another serious complication with a relatively higher incidence of ablations for atrial ablations, and is between 0 to 2%, a little bit higher in ventricular tachycardia ablations, 0 to 2.7%. The basic measure to prevent thromboembolic events is an adequate anticoagulation regimen before, during, and after ablations. Pre-procedure, avoid interruption of anticoagulations, and during a procedure, use intracardiac echo for exclusion of thrombus, systemic heparin from the beginning to the end of procedure, and high ACT target about 350 seconds. What is the safe value of ACT? Intraprocedural ACT reduces the silent cerebral lesion risk of 0.4% for each point of ACT increase. And this table shows that for ACT, about 320 seconds, there are no silent cerebral lesions occurred. At the end of the procedure, we need to close vascular access. Applications of figure of 8 suture is easy and can be described in 4 steps. Firstly, with the sheets in position, suture is passed caudal the skin puncture site, the sheets through the subcutaneous tissue. After exiting the skin, a needle is crossed over the sheets and enters the subcutaneous tissue cranial, the skin puncture site in subcutaneous tissue above the sheets. During sheath removal, the knot is tied with the 2 ends across the puncture. And final result shows the involution of the encompassed tissue by the suture, which results in a complete closure of access site. Like this. In a case of arterial access, we use angiosil, indicated for use in closing and reducing the time of hemostasis of the femoral arterial puncture site. It's easy and is divided into 3 parts. The first part is locate the artery. Second, set the anchor. And the third, set the seal. And now let's have a look at the video demonstrating these 3 steps. Locate the artery, insert the angiosil locator and the sheets over the wire until blood flows over a small drip hole in a system, and withdraw and re-insert to confirm correct location into the vessel. Then set the anchor, insert the angiosil device and click into place and click back to deploy and set the anchor. And finally, set the seal and pull back the device assembly until the suture stops, like this. Knowledge of mechanisms of origin of complications, preventive measures, clinical manifestations, and treatment procedures is essential for physicians performing this procedure. In the last part, I would like to highlight the systemic approach on how to minimize the possibility of complications. The first is be prepared and analyze. Be prepared, at least in the critical patients, have invasive blood pressure monitoring, echo available in the lab area, tamponade box, plan B for cardiac surgery, and standardized workflows. Everything for early detection of complications and early treatment procedures to save patients' life. Perforation of the heart wall with subsequent tamponade is the most common cause of death in connection with catheter ablation. Acute cardiac tamponade is a very dramatic situation that requires immediate intervention in the form of pericardial puncture, aspiration of pericardial content, and introduction of the drain into pericardial sac. In order to perform this step, we must be prepared with a comprehensive package of necessary tools, also marked as tamponade box, and it contains drapes with a hole, 2 puncture needles, scalpel, sheath, large pictal type catheter, kit with a stopcock and a large syringe to withdraw blood into a closed system. Plan before surgery in a case of catheter intrapenial valve. This case is a case of circular catheter intrapenial mitral valve that required a surgery, and this case also demonstrates intrapenial catheter and a mechanical prosthesis. How to avoid complications? This is a complex and never-ending system that based on analysis of complications, incidents, mechanisms, and diagnosis and treatment of these complications, operational standards, focusing on ultrasound-guided venipuncture, transeptal puncture, catheter introduction, and so on. Competence and high volume of cases relates to experience of the operator, and online imaging, focusing on online assessment of anatomy, prevention of thromboembolism, and early detection of complications. Then controlled energy delivery, avoiding steam pop and perforation, and intraprocedural anticoagulation to prevent thromboembolism, and so on, and over and over. Analysis of complication is a systematic analysis of all complications of interventional procedures with a specific tracking system. In a lab report life-threatening complications to the head, online system to report before writing discharge report, and cross-check from hospital info system, and then divided into 3 categories: life-threatening, requiring corrective procedures, and minor complications. Operational standards focus on 3 pillars. The first is that is the process of implementing and developing technical standards. Secondly, helps to maximize compatibility, repeatability of quality and safety, and is the best way to avoid complications of disastrous events. Competence and high volume of cases. This table demonstrates the importance of the experience of the operator. Annual operator less than 25 procedures and hospital volume less than 50 procedures were significantly associated with adverse outcomes. Finally, I would like to highlight the most important things in improving safety in EP lab: analysis of complications, standards, competence, and high volume of cases, high intraprocedural anticoagulation, online imaging, controlled energy delivery, and be prepared is the most important thing we can do for the patient's safety. In this picture at the background, you see me and my cordial friend and colleague Jane Hašková supervising me during my first ablation procedure. It was ablation of AV junction, and from this procedure I am continuously learning curve, making every procedure I perform in EP lab more effective and in a safe way. Always, when I go to EP lab, I repeat a phrase in my head: safety first. That reminds me that the safety is one of the most important things we can give to our patients. Thank you.
Ladies and gentlemen, the title of the presentation is Czech Registry of Catheter Ablations, 3 Decades of a Progress. My name is Robert Čihák. As is mentioned in the title of this presentation, the registry was established in 1994 during first Czech symposium on arrhythmia and cardiac pacing, which was held in Olomouc. At the time, 3 or 4 centers were for the first time reporting about their ablation results. These centers were ICEM, Olomouc, and 2 centers for pediatric population. One is Prague Brno, and another one is Prague Motol, and another one is in Brno. Altogether, it was 180 patients. Most of them were done in last year. But the history of ablations is much older. First surgical ablation of accessory pathway was done in 1968 by Kopp. First catheter and DC ablation of AB node was done by Scheinman in 1982. First DC ablation of accessory pathway by Wood in 1983. And first radiofrequency ablation of accessory pathway by Martin Morgerefe in 1987. First DC ablation here in Czech and in ICEM was done just 1 year after first reporting in the world in 1983 by Švorčík a Bytečný. And you can see ancient equipment of the lab it is Dr. Švorčík, it is Dr. Bitešník. It is a recording of the his from the catheter position on his region. And in general anesthesia was applied shock and complete AV block occurred. First radiofrequency ablation of accessory pathway in adult population was done in ICAM in May '92. It was in cooperation with Centrum in Motol. It was done by Cynthia Tracy from US. You can see how very young she looked at the time. It's a recording system. It's Mingograph Siemens LMR, and it's tracing from this Siemens LMR Mingograph. You can see signals from ablation and mapping catheters. It's starting radiofrequency ablation, a lot of ink all around. And after some time, the recording is then interrupted, is the disappearance of delta wave here. It's used radiofrequency generator at the time, OSIP 200. And these are numbers in the first years. In '97, there was done only 500 ablations. Until 2014, the number increased more than 12 times to 5,800. You can see the increase is quite linear. At the beginning in '97, the main indication for ablation was AV and RT, accessory pathway, and then some cases AV node, flutter, VT, atrial tachycardia, and at the time, no AFib, no curative AFib ablation. In 2000 to 2014, the number of AV and RT increased. It's the same for atrial flutter, VT, atrial tachycardias, a very steep increase of ablation for atrial fibrillation. The increase for accessory pathway was not so steep, not so big, and for AV node, the number were quite stable. It can be seen on this slide. You can see the numbers that are increasing very slowly. But nowadays, the number is more than 3 times higher because we are doing ablation of AV node almost in all patients with atrial fibrillation and CRT pacing or conduction system pacing to allow, as possible, 100 or permanent resynchronization of ventricles. It is a recording for original recording of so-called ablation book from '96. And you can see that this ablation in this patient of accessory pathway, November '96. It was lasting almost 8 hours or even more than 8 hours. And X-ray time, 100 minutes. Second day, again, ablation accessory pathway done by Dr. Kautzner and Dr. Bitešník. Procedure time, 5 hours. And X-ray time, 62 minutes. These are procedure times and X-ray times in '97, 2000, and 2002. And you can see the average procedure time in '97 was for AV node, almost 2 hours, for AV and RT, 2.5 hours, for accessory pathway, more than 3 hours, the same for VT, atrial tachycardia, atrial flutter. When we started AFib ablation, the procedure was lasting almost 6 hours. The long time are also for X-ray. It's X-ray for AV node, 20 minutes, AV and RT, also 20 minutes, accessory pathway, 35 minutes almost, and it's X-ray time for VTs, atrial tachycardia, and atrial flutter. And when we started AFib ablation, it's almost 40 minutes, because at the times we have no 3D anatomical mapping system, no intracardiac eyes, so only X-ray for navigation. And from the history, we are going to present time. These are data from 2020, because we have not yet data from 2021. In Czech Republic, we have nowadays 25 centers that are distributed quite homogeneously across the country. We have 10 million population. The highest density of centers is in Prague and in Brno. There are also 2 centers for pediatric population. So we have 23 centers for adult patients. The number of ablations increased quite linearly starting since 2001. It was 1,300 ablations. In 2019, it was almost 8,000 of ablations. It was going a little bit down in 2020 because of COVID restrictions, but the shift was a little modest. What's the situation in Czech Republic in comparison with other countries in Europe? There are very fresh data, very recent data published in January of this year by European Society of Cardiology. And there are data from 57 countries in Europe and surrounding areas, some countries like Egypt, Uzbekistan, Kyrgyzstan, and Turkey. And you can appreciate that Czech Republic is on the 6th place on ablation per 1 million people. In front of us is Germany, France, Iceland, Belgium, Switzerland, and somewhere in the middle is Spain, Italy, Netherlands, and United Kingdom. So it's quite good position, and even better, it is per ICD per million people. We are on the 2nd place, and the same is for CRT pacing. And there are procedure numbers in particular centers in Czech Republic in 2020. There are 2 centers doing more than 1,000 ablations a year. It's a hospital on Homolka and IKEM. These are small numbers for pediatric population, but in none of these 23 centers or adult population is done less than 50 cases a year. So it's very interesting. The number are increasing all year round. The register is online. So we can see increasing numbers in Homolka, increasing number in IKEM. And at the end of the year, the curves are going a little bit flat. Maybe it's because of some restriction of budget. 62% of all ablations are done in male population, 38% in female population. You can see there is asterisk in one of patient. Sex identification is not known, and maybe number of such cases will increase in the future. Average age of our patients is 61 years. Median age is 64 years. You can see the greatest number of ablation is done in patients between 60 and 75 years of age. The main indication for ablation in 2020 was atrial fibrillation. It was more than 50% of all indications of all ablations. From it is 2/3 for paroxysmal and 1/3 for persistent atrial fibrillation. You can see this number are more than 100. It's because some centers are reporting more than one indication. The second more frequent indication is atrial flutter, typical atrial flutter, and AVNRT. VT ablation with no structural heart disease, it is mainly PVCs, and with structural heart disease together is more than 10%. AV node, 5%, then our accessory pathway, tachycardia of ventricular origin or focal origin, and some other indications. The registry is online, so we can compare our data in 2011 and 2020. In 2011, the main indication was also AFib, but only 66%. Nowadays is almost 51%. The second atrial flutter here is 25%. It decreased to 15%, but the absolute numbers are still going up. They are still increasing. AVNRT, 18%, and now it's 14%. But again, the absolute numbers are still increasing, but the situation is quite different in accessory pathway. The number is still the same. In 2011, 317, 326, there are 330, 320, and 330. So the number for ablation for accessory pathway is the same. It doesn't change at all. Are there any gender differences? Yes, there are. We are doing more ablation in male population for atrial flutter. It is 16%, only 7% in female population. VT or PVC without structural heart disease, it is 7%, 1%. But the opposite is for AV and RT. It is done almost 3 times more in females population. What about procedure times? There are again comparison of data since 2011 till 2020. And in this red column are procedure time for atrial fibrillation. We started with average ablation time 220 minutes in 2011, then 210, 145, 140, and in 2020 is 135 minutes. Nowadays, when we are using some balloons, cryoballoons, and even electroporation, the ablation or procedure times are even less than 1 hour. Its X-ray time, it also decreased very much since the beginning procedures. It's around 3 or 6 minutes, but there is a great variation. More important than X-ray time in minutes is X-ray dose. It's also very low if we are using 3D mapping system and eyes, but it's again great variation in this X-ray dose. For the ablation, we were using in 2020 mainly radiofrequency ablation. It was almost 95%. Nowadays, much less when we start to use electroporation. And the second one was cryoablation and laser ablation. It is done for atrial fibrillation, and atrial fibrillation are 50% of all indication. It means that about 10% of AFib cases are done using cryo or laser ablation. What about mapping systems? We are using maybe CARTO system in 55% of all cases, and NAVEX 8.4% of all ablation. For navigation, we are using very frequently eyes. It's almost 60% of all cases. I think that this number is one of the highest, and maybe even absolutely highest in Europe and maybe in the world. In some patients, we are still using stereotaxis. And it's quite interesting that in 1/4 of all our patients, there was performed CT examination before ablation. In less than 1% of our patients use epicardial ablation, mainly for VT ablations. And if the VT ablation is 10% of all ablation, it means that around 7% of VT ablation are done using epicardial mapping. For ablation, we are using mainly Q-tip catheters. For AFib ablations, balloon catheters, it's about 10% of AFib ablations. For some cases of flutter ablation, we are still using 8mm tip. For conventional ablations, 4mm tip. And few slides from our center, from ICAM. The number of ablations are increasing. Starting 2001, we performed 323 ablations. In 2021, almost 1,200 ablations. You can see that the number in the last 4 years is still increasing here. Going back to history, 2000, when we started with few AFib ablation, main indication was still atrial flutter, AVNRT, then accessory pathway, and atrial tachycardia. And again, only few ablations of atrial fibrillation. 5 years later, the first indication was still atrial flutter and AVNRT, but on the third place was already atrial fibrillation. And we are going to present data from the last 3 years. The numbers are increasing, as I said. The main indication is still atrial fibrillation, more than 50% of all ablations, or almost 50% of all ablations. But the second indication here in ICAM is VT ablation with structural heart disease and without mainly PVCs. So here in ICAM we are doing about 20% of all ablations for VTs. This in comparison with Czech, that's only 10%. And there are ablations of atrial flutter, AVNRT, only few cases, 20 to 30 cases for accessory pathway, and some cases for AV node, mainly in patients with CRT or conduction system pacing. And there is a quite new entity, ablation not for tachycardia, but for bradycardia. It's for patients with cardio-irrigation syncope. We are performing cardio-neuroablations. That is reported here during symposium by Dan Wichterle. So it's quite new entity. So we are going to the end of this presentation. At the end of third decade, we are now changing structure of the registry, adding many new categories and deleting other categories. They are not necessary anymore. The registry data will be connected also to mortality data, which I think very, very important. The other two Czech registry of arrhythmia, it's of pacemaker and ICD implantation, will be also upgraded. So thank you for your attention.
Well, ladies and gentlemen, we are at the end of this afternoon session, and I open discussion. If there are any comments or questions, ladies. Here.
Thank you for very interesting presentations and data, and the number of ice using it's very impressive. Can you still re-sterilize the catheters?
Well, we can, but of course it's restricted, and it's we don't sterilize conventional catheters. The only one is this one. There are also some processing companies, they can do it, but in the US they do it as well. So it varies in different European countries. But of course, as I say, I mean, my colleagues from Poland, for instance, they told me that they cannot, and still it's profitable. If you cut some other catheters, you don't need a high-density mapping catheter for the procedure, but you need ice. So I would sacrifice any other catheter for instance, for VT ablation or for AFib ablation, if I can use ice instead. So it depends on what you believe is more important.
We used quite a lot the ice in Gothenburg, sorry, but until that European registration or legislation came out, and it's not allowed to use medical devices, single-use devices repeatedly. So it's unfortunately we stopped most of them.
Any other question? Well, if I can emphasize a few things, maybe about these complications. I would like to emphasize that if you do procedure, even conventional procedure, you should be prepared to solve complications. And in guidelines of European Society on SVT, there are some mortality cases mentioned even for AV and RT. I think this should not happen. And in my opinion, because I also was involved in some lawsuits when something serious happened during such conventional ablations. I think that's because people are not prepared to do pericardial drainage. So I think you cannot do ablations without training in these procedures like pericardial drainage, because if tamponade happens, I mean, the only way is within few minutes to do drainage, and that's the only way how to treat tamponade. If not, then you can have serious problem. So that's why I put this lecture in these practical sessions, because it's very important to be prepared and solve the problem if it happens, one thing. The other thing is that very few people know what is their complication rate. If I ask you, you say, oh, we have low complication rate. But unless you really have installed system which tracks all complications during the whole year and then analyze these complications, that you don't know what you really have. And as you could see, we have a couple of papers on complications, and we are preparing another one. And only, in my opinion, only when you analyze all these complications, you compare year by year, you see some trends, and you can react. You can analyze root causes of these complications, and you can react. And we changed in last 15 years in the whole department, not only for EP, but we changed a lot of strategies because we learned that there might be problem. Like we analyzed this AFib ablation complications, and we learned that a lot of complications were due to vascular access. So we switched to ultrasound guided, and we show that there is a significant reduction of these complications, namely surgical complications. We had, for instance, cases of pericardial perforation during temporary pacing, for instance, for TAVI or other procedures. Then we learned that this is caused by one type of the catheter, which was very stiff. So we changed our practice, and we use only today USCI BART woven Dacron catheter, which is very soft, and it's very hard to perforate with this catheter, even if you leave it for 2 days inside the heart. So these are examples of how you should work. And it doesn't matter if you are a very big center or if you are a smaller center. But if you are really serious, you should install such a system of analysis of complications, analyze the complications, look at some trends, and then change practice accordingly if you see some adverse trend, I would say. So this is what I want to stress, because if nothing happens, you know, everybody is happy, and you do 100 cases, you believe that you know everything, and then it comes, and it might be a very serious problem. So think about this.
In case of tamponade, in our center, we have started to move from the suprapuncture puncture to the ultrasound guided between ribs puncture or transthoracic puncture. What is your approach?
No, we do. We do always, practically always, subxiphoid, because we do this for epicardial approach, so we know how to do it even without any fluid. Then we feel it's safest, and it's also good because you know immediately you see the wire, how it goes, and this you know, we used to do in my department, this is another example how we change the things. Maybe 15 years ago, elective punctures of pericardial sac were done mostly in echo department, with guidance of echo, you know, fiddling around half an hour, where is a few millimeters more or less. And then we changed, and it's all done now in cath labs, whether it's EP or interventional. And more difficult cases now are done only in EP, because we have the largest experience. And we practically never use echo for, you know, for guidance, only in some very rare cases where you have some localized fluid or at bedside or something like this. But most of the time you can do it blindly. Even if you have X-ray, that's, in my opinion, the best way. And we have, even for this, we analyze about 150 cases of epicardial ablation, and we had very few complications, and none of them more or less was surgical complication. There was only one bleeding from gastric artery, which required clipping, and we had one tear of the right ventricle, but that would probably stop, because the main problem was not bleeding, but the patient had incessant VT, which could not be ablated because of adhesion, so we sent him for surgery, and during the surgery, the surgeon found that there was some tear of the right ventricle, but it was not already bleeding at that time, but it was bleeding for several hours. But these were only serious complications. So I think it shows that it can be done safely, but you need to really to learn from all failures or problems and continuously monitor all complications. And today we started again, this is again learning from these failures. We started to use surgeon in the EP lab if we have adhesions. So if you do puncture and you see there are adhesions, you do not try 1 hour different places, but you just stop and go for surgical, because it's more efficient and safer, definitely. So these are all examples how you can change your practice depending on results or depending on experience.
One more question. So you demonstrated elegant case where you did surgically the cryoablation. Have you tried cryo through the puncture in the epicardial area? Pericardial area. You had some VT case when it was close to the coronary artery, and you did a cryoablation through the surgery. But have you tried the cryo catheter in the epicardium through the puncture site? Well,
it was quite a long time ago, and we did not try to do this. But today probably we would. Well, it depends. I don't know. Probably we would do cryo today with a point catheter, or we would do probably now. We would try maybe pulse field. Well,
probably the cryo close to the coronary arteries is safer, probably.
Oh, there are some experimental studies that you can do pulse field, you can apply across the artery and nothing happens. So it's yeah. These are, rare cases, but again, it gives you a lot of input, usually such specific cases, because you learn a lot of things, and then next time you can do it maybe simpler or easier. But again, also shows what I mentioned, that, and we see this also in this country, and I see it in other countries. If you cannot do something, that's acceptable. I mean, if you do 20 cases a year, or if you do 150, that's a difference. And you have more equipment, and you have more people around. But if you fail, you should send patient to another center, and not to keep a patient on amiodarone or tell him that nothing can be done for you. And this is a problem that sometimes people don't accept that, you know, not everybody can do everything, obviously. I'm talking mainly about VT or some complex atrial arrhythmias or congenital heart disease patients. So it's not shame to fail if you are not expert in the field, but you should really suppress your ego and send the patient to a center where they do have this experience and they can do it. There's nothing wrong about this because it's mainly patient interest, not your ego, which will be harmed if you send patient to another center, probably. I don't know. Any more questions? Everybody is looking forward for dinner or some walk in Prague, okay? So thank you very much for coming. It was a sort of small group, but I hope that tomorrow there will be a more interesting program and you will see a lot of new strategies or technologies and nice lectures. Most of people from international faculty will arrive. Some of them had to give up and they will connect online, but very few. And so I believe that the meeting will be successful and have a nice evening, good dinner. Be careful for nightlife, because otherwise you may not enjoy tomorrow morning if you drink too much or eat too much, which is easy in Prague, but see you tomorrow.